Okay, here we go, and action.
Good afternoon. Welcome to our COVID update on June 18th, 2020. I thought I would start off by sharing my experience getting tested today for COVID. It is a little uncomfortable. They take the Q-tip and stick it pretty far back up there, but it's really a transient discomfort, at least it was for me. And afterwards, that side of my nose, for me it was the right side, was a little clearer, my sinuses, so it goes back there pretty far, but it wasn't too bad. So if you decide to go get tested, I did have a question about this. I went on my lunch hour, and so you'll need to do it outside of work hours or take time off to do it. They do have hours on either side of our work hours, so you should be able to find a time. That's at the sites that are at City College and in Sanger. I know there's some labs, and maybe your primary care provider also tests for COVID. But for the ones that are through the county, they do ask you for your insurance information, but if you don't have insurance, you can still get tested, and the county is paying for that. So we're really trying to get our test numbers up. It's one of the ways that we're working with the state to ensure that we're doing everything we need to do. And so the more people that get tested, the better. If I find out that I'm positive, I will be isolating, and I should get my results back next week. So June is Pride Month. We talked about that the last couple of weeks. So I thought I would just highlight one individual, particularly with the racial injustice issues that are being highlighted right now. I thought I would highlight an individual that kind of crossed both lines. Bayard Rustin was a civil rights leader and also a gay rights advocate and leader. He worked on ending discrimination in employment. He worked alongside Martin Luther King on nonviolence. And he did receive the Presidential Medal of Freedom posthumously. So a shout out to Bayard Rustin as we celebrate Pride Month. All right, COVID world numbers. As of today, there are 8.4 million COVID cases and 451,000 deaths worldwide. As I was preparing the presentation today, I looked back at my very first presentation to all of you, which was on March 13th. I actually printed it out. I'll show you here this slide. Back then, we had 137,000 cases. We're now up to 8.4 million, and we had 5,000 deaths across the world, and now 451,000. So significant increases in that period of time. In the United States, we have almost 2.2 million cases. Back on the 13th, we had so few cases, it wasn't even separated out for the United States. I think on this that I printed, in terms of deaths, there were 31 deaths in Washington State, and that was the highest state in the United States at that time. And we've had about a little over 118,000 deaths. For California, we're up to 157,015 total cases and 5,208 deaths. This is through yesterday. That's how the state reports. They're about a day behind. So last week when I reported, it was as of June 10th. So we've seen an increase of 20,000 cases over the last week and about 432 deaths. And for Fresno, we went from 2,318 cases last week to 2,900, and from 49 deaths to 61. If you look at the week prior, we had an increase of 404 cases. So we have more cases this week and about the same number of additional deaths. I will again caution you that the deaths are delayed in their reporting. So the 61 deaths through yesterday are not necessarily all the deaths that ultimately will be recorded for that time frame. Okay, so I'm going to talk about a few things. I'm going to first talk about how are we going to ensure safety in the workplace. I will say that our CAO has extended the emergency telework authorization through the end of September. And as I've mentioned the last couple of weeks, we are only slowly and methodically doing a return to work, and I'll talk about that a little more. But as we prepare the workplace for more people to come back, ultimately, we are developing safety plans and we're trying to promote a safe work environment. So this slide kind of shows you what do we look at, and there's what's called a hierarchy of controls. And the hierarchy of controls look at, can you physically remove the hazard? That's called elimination. If you can't remove the hazard, can you replace it with something that's safer? How do you isolate people from the hazard? What kinds of things can you change in the way people work to protect them from the hazard? And how do you protect the worker with personal protective equipment? So what I'm going to talk about is specifically with COVID-19. COVID-19 is the hazard. So eliminating the hazard originally was that stay at home, shelter in place. If you're not out and about, you can't get COVID. The wellness screening that we're doing is an example of eliminating the hazard. We don't want you here if you're sick. Limiting unnecessary trips and having travel restrictions were all things designed to reduce the risk that you would be exposed to the hazard of COVID as a population. And so in the workplace, those are things like the wellness screening and such. The second thing you do is substitute or replace the hazard. That's not possible with COVID-19. There's no less offensive hazard we want to replace COVID-19 with. And then if that's not feasible, you go to the third phase, which is implementing what's called engineering measures to isolate the employee from the hazard. And so for us, the kinds of things we've been doing is installing plexiglass barriers, looking at our air ventilation, making sure that we have good ventilation in areas. And then if we can't address all the hazards that way, then you develop what's called administrative controls. And these are changes to how we do the work. So telework is one example of how we implemented an administrative control. You're still working, but we changed the way you work. That creates a way to keep you from the hazard. Now, we can't keep you from going out and about out of your home. So from a workplace perspective, that was a way of keeping the hazard out of the workplace. Looking at things like the staggered or rotating schedules, so either having people start and end their work at different times to have less movement in and out of the building together, or rotating work schedules, which we've talked about, which might mean 2 or 3 days a week that you work from home, 2 or 3 days a week that you come into work. And then worksite configurations to physically distance you from one another. We've talked about the hand washing that's required, heightened cleaning and infection control of our areas, changing that practice, and then wearing the mask at work. Today, the governor announced that in California, you will now be required to wear a mask in public. It's my understanding that there was some confusion about some of the verbiage in that order, so our county is working with the state to get resolution and clarification. This is sure to create some additional outcry from the public that their rights are being violated to be forced to wear a mask. But this is a new order from the governor that just came out around noontime today, requiring individuals to wear a mask in public. So stay tuned on that one. But the interesting thing is that personal protective equipment is actually considered the least effective method of keeping people from a hazard. And so we use it when we cannot avoid potentially being exposed to the hazard. That's why our clinical teams who are still doing in-person care are using protective equipment in every encounter, and we have even more heightened administrative controls in those areas where we still have the people we serve coming for service. And so it's interesting, I think, to think about it that way, that it's the least effective. Staying away from the hazard is the best. So again, I know there's questions about whether your rights are violated to wear a mask, but there are things that we can do, the physical distancing, the hand washing, the mask wearing when in public, that truly do have the means to protect you at least somewhat from the hazard. And so that's why we're emphasizing them so much. And again, as we learn to live with COVID for the foreseeable future, we talked last week about the progress in vaccines and such. anything we can do to slow it down is good. And our local hospitals have seen an increase in hospitalized individuals with COVID over the last few weeks. So this is a great concern. We want to be able to have businesses open and the economy restart while we keep people safe. So that's why we do all of these different steps. So this is a busy slide again, so I'm going to talk you through it. Just wanted to talk a little bit about what do we know about how COVID spreads. There's an article in the Wall Street Journal today that indicates that we're really beginning to believe that touching a surface that someone else has touched probably isn't the most likely way that it's spread. Passing each other in public, particularly in outdoor settings, probably not the way that it's spread, but really it's that close contact in either poorly ventilated or close quarters over an extended period of time. And so as we are learning more all the time about COVID, and as we learn more, that's why sometimes the recommendations change, and our ability to be flexible is really important. So I thought I'd talk today about what is a super spreader. I don't know if any of you have heard the term super spreader, so I'm going to talk to you a little bit about that. So I'm going to give you a little epidemiology background. Some of you who are news geeks like me or science geeks may have read about this, but RO is something that's called the effective reproductive rate of a virus. And it measures for each person that's infected with the virus, how many people do they infect? And different viruses have different ROs. Some, like a common cold, have a pretty high RO. I think it's measles is 10 or 12. And others, and some of the prior SARS-like viruses had a smaller R. Anything over 1 for an R, which means each person is infecting more than one other person who they give it to, is associated with increased spread of the virus. So the higher the R, the more people that person with the virus tends to infect. If an R gets below 0, and this can change over the course of a virus, particularly as people develop immunity to it, it typically results in the virus dying out. That's why you isolate people who have the virus. The fewer people they're in contact with, the fewer people that they spread the virus to, and that's how in the beginning of a virus, when we're trying to do containment, that's what we're trying to contain, is the number of people that each infected person infects with the virus. And then K is a dispersion factor of the virus. And this measures the concentration of infection in a geographic or environmental measure. So we see, do we see dense clusters of infection, or are the patterns more dispersed? So a lower K value really implies a greater clustering of the virus. So it means a smaller number of people are responsible for more infections. And that is typically what's considered super spreading. And there's two ways that a super spreading event can occur. Preliminary data suggest a pretty low K for COVID-19. And so that means that we think there's more clustering of the virus than just broad spreading of the virus. We don't know the R value right now because it's hard to, we're doing contact tracing and there's lots of activities going on. Eventually we'll understand better as we get further along in the virus. For each person that gets the virus, how many people are they infecting? But right now we don't know the R, but we think it's relatively lower. Not a lot more than, say, 1, 2, or 3. So we think that there's clusters. So how do clusters occur? Well, there are individual factors. Depending on which stage of the virus a person is in, they might shed more virus particles. That's why this concept of asymptomatic spread and why we wear our masks, so that if we're actually shedding virus before we know we're infected with the virus, we're not giving it to other people. And then different people, they think, have different virus shedding potential. So what that means is I might have the virus and you might have the virus. We might be at the same exact stage of virus, but for some reason my body has a different immune response, maybe because of past infections I've had, maybe because of my blood type or genetics. We really don't know. But where I'm shedding more virus than you are at the same stage of the virus. And so individuals like that could be spreading more virus, infecting more people, increasing the R, simply because they're shedding more. And then there's environmental factors, and those are things like if the person at the time they're shedding more virus is in an indoor environment in close proximity for long periods of time to people, there's a better chance that you're going to have a lot of people infected. They don't know about the temperature if you're in a cold environment. And then if you're singing or shouting or exercising, you might spread the virus further. Remember last week we talked about how fast the air particles, the moisture droplets go out of your mouth if you cough, if you sing, when you breathe. Those types of activities spread the virus more broadly, and that could result in more people being infected by one person. And then if you have a lot of diverse interactions, if you're going from one place to the next, you could potentially spread the virus a lot more in that way. So we don't know. We think that there are some high-profile events, and there's some settings that appear to be higher risk for spread. So right now, they believe about 40% of the deaths from coronavirus have happened in nursing homes. And there's two factors we think going on there. One is the age and the comorbidities that people in nursing homes often have. They might have those underlying health conditions, really the higher risk factors by age and underlying conditions. But it's also the nature of the environment. You have a close environment. There might be 2-3 people in one room very close together. If you have a staff member who has COVID and they're going in and out of those rooms daily, they could spread it to more people. They think that's what's happened in some of these largely spread outbreaks. A large number of the deaths in our county have happened at a few different long-term care facilities. And so those are just examples of how a cluster of virus and a cluster of deaths could occur. We've also had some clusters occur in home environments where there's a lot of people living together, particularly multi-generational. And so those are the types of things that as the virus goes on and we learn more, we'll be able to give maybe different but possibly better advice and guidance, and it might also change the restrictions. We might have a loosening of restrictions for outdoor activities, but a heightening of restrictions for indoor activities. And so that's a little bit more about COVID. All right, so what are we doing? I alluded to this earlier. We are analyzing our return to work requirements, putting the finishing touches on our written plan that takes into consideration all of that hierarchy of controls that I mentioned. Continuing to assess telework, both short-term and long-term. That current plan, as I mentioned this last week, our CAO extended the emergency guidelines to allow telework through the end of September for now. And so we may have some non-clinical areas begin a gradual return to work, but only based on work need. And what I mean by that is there are some tasks and activities that have to be done in the office. And that could be something as simple as making copies or things like that, or it could be that an interaction has to occur with a client while they're here. And so we are going to be bringing some people back based on our work need. We might also bring people back if they can't effectively conduct their job from a telework environment. If we do this carefully and methodically, even some people who come back, the fewer people we have here, the easier it is for us to keep it easily safe. And then we're also, because it looks like telework's going to continue a little longer, we will be adopting or developing some written guidelines around telework. And that will that will we hopefully help to set expectations for those of you who are teleworking and supervisors to ensure that everybody understands the expectations and that we have a mechanism to ensure that the work is effectively getting done. So you should look forward to that. Of course, we will continue to daily screen for health. Something should be coming out in the next few days. I cannot emphasize enough. I know you guys are sick and tired of me talking about do not come to work if you're sick. If you do come to work when you're sick, known sick, then you could be subject to disciplinary action. Please don't come to work sick. Don't put us in that position. And we continue to acquire and stockpile our own personal protective equipment just so that we're ready should we have an increased need or should there be a shortage in the supply chain. So all of those things are ongoing and going well. And so at this point, I'm going to move to the question and answer session. I will let you know that next week I have a week off. When I first planned this week off, I was going to try and work from home. But I've decided that it's not a very good model if I can't take some time off. And many of you who know me know that I kind of build into my schedule every year a number of time away from work. It's part of my own mental health and well-being to take breaks. This job is hard, as all of yours are hard, I know as well. And for me, that is how I get my break. And so taking time off should not be perceived as a weakness or a deficit. For me, it helps me stay strong. And so I highly encourage all of you. We've been through a really, really tough time. It increased anxiety at work. It's increased anxiety in our homes between COVID and the racial unrest. We really, really have had a lot on our plates and meeting the needs of a very vulnerable population. So I really encourage people to take time off, help refuel yourself, restore yourself. It's hard to be there for others when you haven't taken care of yourself. And so that's what I'll be doing next week. You won't see me sitting here. There might be someone else, we'll let you know, but I'll definitely be back the following week. So I'm going to take a few questions. The first one, is there an update on the timeline for an unlicensed clinician position being available? I think I gave this timeline last week. We're finishing the job specs. We're trying to include licensed and unlicensed professional clinical counselors in our job specifications. We really have had to work hard to get enough clinicians, and we think by updating those job specifications, it will increase the number of people eligible to apply for the position. So it is taking a little while. COVID's definitely slowed things down, but that is on our list of things to do. Does the governor's order to require masks in public impact the return to work plans? No, they don't impact it at all. We had already implemented, or in our clinical areas, masks are already being worn. And as we contemplated bringing more people back to work, I think I've mentioned in other meetings that we did contemplate that these masks or some sort of mask would have to be worn anytime you're in an area where other employees are, particularly where you're congregating. So common areas, entry and exit from the buildings, hallways, bathrooms, break rooms, that type of thing. So we don't anticipate that changing the plans. And then providers are asking about where to acquire PPE from the county. Retailers are still out. Great question. I'm glad you asked. We have actually provided some of our providers with PPE. A couple of times I've sent out information to our providers letting them know how they could make a request and receive PPE. The Department of Public Health, along with Internal Services Department, our facilities department within the county, has begun to acquire PPE for providers to purchase at cost from the county. And so if you know of one of our providers that needs PPE, they could contact us through our Human Resource Department, Helen Herrera, or Matthew Frias. Can assist them with either acquiring PPE from our department or from the county's, we'll call it a stockpile, of PPE. And that PPE is being made available to medical providers, dental providers, anyone who needs the PPE in order to do their job and get their business back up and running. A lot of dental providers got delayed in that because they had a hard time getting PPE, and so the county is assisting with that, which is a really great thing. They've acquired as many as like 1 million masks, and that's really, really good for all of us. Are homeless community members going to continue to be housed in the emergency shelters set up in recent months? Yes, so right now, and I think most of you know that I'm part of the leadership of those efforts. And so we're really pulling together different sources of funding from the city and the county made available through COVID relief to extend the shelters as long as possible. And so right now, our plan is to continue shelters through the end of September at least. We'll continue to look at those plans and the funding as we move along. What we're doing while we have people sheltered is we're really trying to screen for need for mental health and substance use disorder services and physical health services and housing need. And so we've provided everything from each homeless shelter now has an iPad that connects them to a physician with the UCSF residency program, so they can do a medical consult if they need it. We've worked with our shelter providers to get medications on site, including narcotic treatment medications like methadone. So if we have someone in a homeless shelter that needs to get methadone, during the pandemic, we've arranged to have methadone taken there. Our next step is we're going to be looking at doing medication-assisted treatment starts in the homeless shelters. And so we put a lot of resources around this. We really want to take advantage of a time when people are engaged and sheltered to try and get their needs met. At this point, we have had some people exit shelter to go to housing, and we've had some people exit shelter to go into treatment or rehab. And we've had people exit shelter because they don't want to be sheltered or they're tired of it. A lot of them have come back, which is great. But we continue every single day in the metropolitan and rural areas. We have rural outreach teams as well to go and engage and speak with individuals who are experiencing homelessness and offer them shelter and house them as much as we can. We've created about 450 additional shelter beds through COVID funding. And that includes individual locations where there's small living arrangements. We don't have big rooms with bunk beds. That would be unsafe with COVID. And then also we have some trailers, some FEMA trailers that were made available to us through the state, as well as some motel rooms that we're utilizing, particularly for people who are waiting COVID test results or may have tested positive. All right. What is the plan if COVID cases go up in Fresno in the coming months? Well, as I've mentioned previously, COVID cases are going to continue going up. What we'll be watching for closely is hospital capacity. And as hospital capacity becomes compromised by COVID, then those are the types of things that might trigger a rollback of some of the reopening. In talking to our public health officer, Dr. Reyes Bora, and our public health director, Dave Palmaville, they are watching a number of things very closely. I think that things like having an order to wear a mask in public will help us. I don't know, I've been out and about, and I know in Clovis they're not requiring a mask. In retail establishments in Fresno they are. Even in Fresno, I've seen some people appears to me defiantly not wearing masks, but hopefully some of that will go down. And you know, I've heard a couple of stories now that have happened to people living in Fresno. And you know, I would ask you all, I'm going to tell you my experience, and I'll talk to you about my husband's experience, because I know most of you know he's an emergency physician. I only can recall one person in my lifetime that I know for a fact died of the flu. And it was a young boy who was a friend of one of our children's sibling, and he developed the flu at the same time as another bacterial infection and very rapidly declined and died several years ago. But other than that, I can't recall a single person that I know that acquired the flu and died from complications of the flu. And I asked my husband that question: how many people came into the emergency department and, as you recall, died of the flu? And he can't recall really hardly any either. And so I think as more cases occur, we are going to be touched personally by this. The gal that I run with, we were on a walk last weekend, not running quite yet with my knee, and she relayed that someone she goes to church with had gotten COVID and had a 6-year-old son who acquired COVID from her. He gave it to the grandparents, and the grandfather died. And then a colleague of mine relayed going to an event with family, and everyone was wearing a mask, and they felt like they were social distancing. Unbeknownst to them, one of their family members was sick, and 9 of the people at the event came down with COVID here in Fresno County. And so I think until we really begin to personally experience the impacts of COVID, it doesn't feel as real to us. But we're going to just have to watch closely what's happening in our hospitals in particular, what's happening with the number of deaths, and whether or not they're isolated to certain settings like the nursing homes versus broadly in our community. All of those variables will have to be taken into consideration. Certainly our ability and willingness to conduct ourselves in a way that does everything we can do to protect our community will help us not get to the point where we have to roll back some of those measures. But that's always a possibility. So those are the things that are being watched very, very closely. And I will just say you should rest assured that there are lots of people focused on these metrics that need to, including the state. I will say this week we had a state monitor on our public health call who is, because we're one of the counties in the state that's moving forward in the reopening, but experiencing increasing cases and deaths that are continuing to increase. The state's monitoring us. So it may be taken out of our hands at some point if we can't get a control on the number of cases and the number of deaths. Our interviews and promotions going forward during this time, both of those things are happening on a case-by-case basis. So we have identified some priority vacancies to fill, and those are moving forward. And I don't believe the promotion process has changed. I know I've signed a few of those. So I believe those are going forward. Let's see. I don't see any other questions in the chat box. I'll give it another minute. Sometimes it takes a little bit for people to either think of a question or be brave enough to put it down in the chat box. Still nothing there. So with that, we'll end today's session. Again, a reminder that I'll be taking a break next week. And again, that I encourage all of you to take the breaks you need as well. And we will stay in touch. Thank you.